chairperson and audience. When we see all these gamut of tests, even then our patient comes with rejection. So there is beyond HLA. That is why my topic is beyond HLA, emerging biomarkers and non-HLA antigens. So I'll just briefly tell about emerging biomarkers and technological advances in biomarker detection and impact on transplant outcomes, future direction and results. There's not much of studies on impact. We'll anyway. So role in immune response, as you all know, biomarkers provide critical insights in the immune response of transplant recipients, assess graft function, and also it helps in predict rejection, and also tailor to immunosuppressive therapies. That is why we need to know about biomarkers. So what are the emerging biomarkers? This is the most important biomarker we are already in use. And the importance of this is the test does not need previous genotyping of the donor or recipient. You need not know the HLA because most of our patients who come for review does not have any reports of prior HLA typing. So this is the advantage of donor cell-free DNA. And another most important advantage is it is elevated during acute rejection. And also it declines within following 3 months. Now we just follow the creatinine. If creatinine comes from 1.6 to 1.5 or 1.4, we are happy and we tell the patient that this our rejection is treated well. But it is not the case because there will be ongoing rejection, we are not rejecting. So probably more usage of cell-free DNA is warranted because of this. So this is an important biomarker. And is there any evidence for that? Definitely the evidence are found. The admitted trial is clearly demonstrated a lot of cell-free DNA and indicate the effect of legal preservation. So it can be used as a monitoring tool and also we can assessing the removal of the shot and also use the so this is very important, probably the most important advanced transplant diagnostics is monitoring of the data. And another important is coming with the practice of technical blocking protocol. This is otherwise known as accessory to the target RNA expression sequencing. So people have tried the 70 gene set sequencing model which can diagnose certain infections, including the modernization of the identified human residents account in high risk for serological and decline level. So these two may combine together to give a very good result in monitoring the graft response to the immune response software model. So this is a very important paper which combines these two and give out good results. So want to look at it, better to advise the researchers. And another important China we all take during our project is forming space this transcriptomics, genomics, metabolomics, and proteomics. So now a lot of papers are coming out with gene expression profile and what is transcript of the gene and what are the proteins which produced by the gene and what is the metabolic changes which occurs with the expression of these molecules. So now people are actually identifying of molecules which not be identified clearly or not be active clearly, but there are probably will become a future marker. So what is knowledge language? Now you come to knowledge, this is a biomarker, now you come to knowledge language. We talked about a lot of examples. Now we talk about knowledge language. Probably translates may require 1 year, 2 years to discuss knowledge language next year. This is a most important thing. What is the mechanism of knowledge language? In pre-transplant also you have a tendency to have a knowledge language, and in post-transplant also you can release knowledge language. This is all because the endothelial injury. So endothelial injury, like this endothelial activity in the brain, and finally there is a knowledge antibody formation. Another around 10 to 30 knowledge antibodies identified, which can cause autoimmune reaction. This is the method identified antigens. I will keep a list. This is the total monoclonal antibody identified present, and all can cause complete activation and antibody inhibition. So Probably our area which is secondary negative, and also we say this is negative, and why it is rejection. Probably these are the factors which cause rejection. So we need to have a very good history to understand is there any probability cause which can elicit this avoiding response or this is not experiencing response. And also when there is an unexpected response, there is an interaction with the HLA and cause this
complementary to each other and cause rejection. So this is very important. This is a very good article in. So what is the future direction? We need to characterize which are the antibodies. We need to have a good genetic analysis and incorporation of non-HLA antibodies in immunologic risk assessment. We now talked about, in the whole day, we talked about immunologic risk assessment based on your HLA. But we need to identify which are the non-HLA antibodies which can cause rejection. And also we need to formulate guidelines for that. So in summary, we need to identify the non-HLA antibodies. Clinical relevance is dependent on the tissue expression. Non-HLA mainly have detrimental effects, we all know that, and lab guidelines to harmonize and validate the non-HLA antibodies. So we have a lot of work to do in the field of non-HLA. HLA we have done a lot. So now, so why we need to have a good immune tolerance? Because from this to that young boy, beautiful boy, to a youthful man, this is the how transplant transforms. We need to talk about long-term outcome, not immediate graft survival or a not 1 year survival. We need to look beyond that. So everyone, whoever comes to this session, the aim should be to improve the transplant outcome from 1 year to 10 years to 10 years to 20 years. So this is how transplant transforms. And for my all fellow colleagues who work in the hospitals, tell your ICU colleagues to identify, declare, and notify brain dead. This is my appeal to all the transplant nephrologists. Thanks for the patience. This is all my talk. Thank you.
Thank you, sir. It was very insightful and comprehensive presentation. So it's very clear that HLA antibodies is insufficient in assessing the immunological risk in transplant. Non-HLA antibodies are emerging. And as of now, we don't have
test or treatment
recommendation or guidelines on it.
Right.
So if when to do it, non-HLA antibodies, pre-transplant or post-transplant?
Both. There is a chance of non-HLA antigens developing pre-transplant and post-transplant. So it can, now the well characterizes AT1 receptor antibody. When they say when you have a steroid resistant rejection, you have to check AT1 receptor antibody, and there are a couple of studies which have, and as a prophylactic, they recommend angiotensin receptor blockers to prevent this AT1 receptor antibody mediated rejection. So probably in a couple of years, we will have a lot of antibodies which acting as immune molecules for it.
And both work synergistically also.
Yeah.
So if both are there pre-transplant, how the desensitization differs, how we should proceed or not?
They say this imlifidase, that is septocyme B antibody, that and all is useful for this, but no solid evidence for any of this. We need to wait for that, probably.
And post-transplant also, this can present as COD negative and DSA negative.
Correct, yeah.
So in that situation, a patient with refractory to treatment, we should think about this.
Yeah, correct.
And that also will change any treatment?
At present, no. At present, no.
And is there any role for like HLA matching, non-HLA antigen matching, pre-transplant?
No, non-HLA antibody, we have a lot of non-HLA antigens in your body, and we don't know which antigen will come up with what stimuli, because viral infection, AT and AKI is, all these causes, whichever damages the endothelium can generate endothelial-based antibodies, which can be anything in the base membrane, anything in the endothelium. So will be very difficult or very challenging to characterize all these non-HLA antigens.
The topic is open for discussion or questions.
This AT1 receptor mediated rejection, probably we do come across fairly frequently. Okay. I remember seeing one patient after second transplant develop severe rejection with refractory hypertension
Oh,
requiring
yeah.
multiple drugs. And with the addition of ARB,
It came
it
on.
came down. But there's no way of making this diagnosis. So it suspected the possibility of this, and patient responded to ARB, like
Okay.
angiotensin receptor blockade.
Yeah, that is a very important clue. They say steroid resistant rejection with refractory hypertension is a clue for AT1 receptor mediated, antibody mediated rejection. That is a very good clue, sir, sharing from his experience. Thank you, sir.
I think, Dr. Satish, you had a kit that you got from Germany regarding
Okay.
the donor-derived cell-free DNA. I think you can share the experience on that.
Yeah.
Actually, we did receive, and I had posted a case on the ASN forum regarding one of the patients with eosinophilic rejection.
Okay.
And then after some time follow-up, somebody from there sent me a kit. I said, we don't have DDCF DNA in this country. So he sent me a kit. And then that kit was valid for 24 patients. For
Okay.
2 they had taken for validate, so we did for 22 patients finally. And all of them with either rejections, ATN or whatever, all of the graft dysfunction. So only one patient, the ABMR, the value went about 2%.
Okay.
And all the others where there was no rejection, the value was below normal.
Yeah,
And
it's
those with
good.
ATN values very well below 0.5, using a cutoff of 1%, more than 1%.
Yeah, 1%
2% was
cutoff,
only
yeah.
for those with rejection. So it looked very good.
Yeah.
But studies have shown it's very good as a negative predictor rather than a
correct.
positive predictor.
Correct.
So if you do it and find that it's not there, probably you can avoid a biopsy.
No, probably Antonio will add cell-free DNA in your immunology lab. Thank you.
Is it being done commercially? I think Dr. Sruti's lab in Bombay does the endothelial antibody, I believe.
The Lalpath also is doing.
Yeah. So many
The
labs
labs
are
are doing.
currently doing
But
it.
we don't know how it's standardized, because it's very important that less than 1% and more than 1%, how they reached at that value in each lab. Like the standardization flow cytometry, this cell-free DNA assay standardization is a very cumbersome thing. So we can't rely completely on that.
Yeah, I think I don't know what the pathological correlation. Did we have any pathological correlation in the number of cases you had, or anybody has any experience on that?
Okay.
Because we had the kit and the patients were already there, it was actually post-biopsy. So we confirmed within that we didn't use for diagnosis, we used it just to see whether the test was actually predictive, because that way.
I feel this particular test is particularly useful in patients whom biopsy is not possible. For example, the patient is on anticoagulant which cannot be discontinued. In such a situation, this will be very, very reassuring. The test comes reported as negative.
Correct.
Be very reassuring.
Thank you.
We have some time, I think. So any other
No,
questions?
because we long case discussions are coming up. That is why I
So,
cut short my
Shall we
presentation.
close? Yeah. So thank you, Dr. Noble. That was a wonderful presentation.
Thank you, sir, for